A Northwestern medicine study just out shows slow hospital transfers are costing lives here in Illinois. And Dr. Ann Stay is a trauma surgeon at Northwestern Medicine. She joins us now live to discuss her findings. Doctor, appreciate it. This is a big problem that hasn't been studied before. Can you start by telling us how bad the problem is and why do you think it hasn't been studied until now?
Yes, thank you so much for the invitation. The problem is that about 30% of people who have a life-threatening injury are often taken to hospitals that don't specialize in injury care. And then about half of those people will then never get transferred to a hospital that does specialize in trauma care. So we know this is a nationwide problem. This is not just Illinois. This is something that has been studied around the country over the last couple of decades. And the reason that's concerning is because we know from work that's been done over 25 years ago that people are more likely to live when they have life-threatening injuries when they're taking care of at hospitals that specialize in the care of the injured patient.
All right. Well, I think we can all understand why we want to make it better here. So in the report, what came out, it's more than just a manpower issue, right? It begins in the evaluation process at the lower trauma hospitals. Can you explain the primary causes that lead to the delays that you uncovered?
Really what we found was we were the first to understand from emergency medicine physicians, emergency nurses, hospital clerks, hospital transfer coordinators, trauma surgeons, and trauma coordinators at both non-specialized hospitals and specialized hospitals, what steps in the process make it hard to transfer an injured patient to specialized hospitals. And what they told us was that staffed beds availability at these specialized hospitals was unknown oftentimes, and that it was hard to then coordinate the movement of severely injured patients safely because of a shortage often of highly trained paramedics to move patients between those different hospitals. And also, they noted that it was really difficult to move patients' medical data between hospitals.
I think we have this image of like an ER doctor with a Rolodex trying to reach out. What did the study reveal then in terms of like the decision making and the coordination when seconds count when you're talking about a serious injury or an acute illness?
Yeah, so the decision making is often really at the discretion of the provider that is taking care of that patient at that moment. And that can be really difficult because these are really high stress moments, like you mentioned. And so we heard from certain ED doctors that explained they were spending 3-4 hours just calling hospitals, begging them to take one of their patients who was really sick. And you can imagine an ER full of, 50, 60 patients that need to be seen by that one emergency provider. That's a really difficult process. And that's also an extremely stressful place to make a decision. And so having these individuals feel like they're working through silos makes it really complex. And often what ends up happening is people fall back on the connections that they have, their network that they have, people that they've worked with before, whether it's in different clinical scenarios or sometimes even back in training or medical school or in different hospitals that they've worked in.
Okay, so the bottom line is, what are the solutions here? How can you make it better? And how can patients and their families advocate for the people that need the care?
Yeah, absolutely. Here in Chicago, we have a really unique situation that really allowed us to be able to study this problem. We have the first hospital that specializes in trauma care, Stroger Cook County, and that's the first hospital in the whole world that specialized in trauma care. We also have a single internationally renowned pre-hospital provider doing the vast majority of our transports and a really supportive city and state Department of Public Health and a tightly knit trauma community. So we were able to really ask and answer these questions. And there are already solutions that are being implemented. And so one solution that many of our providers identified is a bed tracker to know which hospitals have a staffed available beds and which hospitals don't. And the Department of Public Health actually already has that in place since the early 2000s. And the Chicago Department of Public Health over the last couple of years has even improved on that bed tracker in the last couple of years by creating an API or an application programming interface. And what that does is it allows the hospital to directly feed staff bed availability numbers directly from the electronic health record to the EM resource bed tracker. This is a critical step forward because it lets the non-specialized hospitals know which specialized hospitals have staffed beds available, so they don't waste their time calling hospitals that don't have a bed available.
Use that technology.
Exactly. And this is an ongoing program the CDPH has rolled out, and it's been very successful. And we want to raise awareness that any hospitals in Chicago wishing to join and participate can continue to do so. There are other solutions that have been identified and implemented in other states. For example, during COVID, the public health emergency allowed Arkansas, Washington, Oregon, Minnesota, and Arizona to build these centralized transfer systems. And that gets at that problem of moving patients between hospitals, because these centers really are working closely or even employ pre-hospital providers. But the problem is these centers also need funding. And so they need taxpayer money to be able to help stand up these types of centers. It takes money and trained clinicians who are able to work in those centers 24/7.
Sounds like a familiar story. We're going to have to leave it there. Dr. Stay, we're glad you're putting the focus on this to make the problem better. Thanks so much.
Thank you.
Take care.